Good afternoon or evening if you're joining us from the East Coast. My name is Robert May. I'm the Executive Director here at the Kensington in Redondo Beach. Kensington Senior Living has 7 unique communities, 4 located in Virginia, Maryland, and New York, and 3 sister communities in California. Kensington is truly privileged to support care partners and professionals from coast to coast this afternoon. Kensington focuses on relationship-based care built on the foundation of our promise to love and care for your family as we do our own. It is programs such as the one you're going to attend now that are so important for those of us who are walking through as the caregiver journey to hear from expert professionals on keeping us current with the latest advances, care management, and treatment of conditions that affect seniors and families. Today, you are for quite a special opportunity to hear from top neurologists about Alzheimer's and brain disease. November is National Alzheimer's Awareness Month, and we are excited that you are joining us. Today, Lauren Miller Rogen has joined us at the Redondo Beach community to broadcast live and also spend time with our guests following the webinar. We are also grateful that Dr. Travis Urban and Dr. Irina Schuyler Scott are joining us from our community from Northern California. Thank you. Everyone that registered for today's event will also receive a copy of the webinar to share with friends and family. And please remember to utilize the Q&A function to submit questions for our panel. Join me in welcoming Lauren Miller Rogen to moderate this discussion. Lauren Miller Rogen is an American actress, comedian, screenwriter, director, producer, and a remarkable philanthropist who was profoundly affected by the effects of Alzheimer's when her mother was diagnosed with this pernicious disease at the young age of 55. Lauren co-founded HFC, Hilarity for Charity, in 2012 with her husband, Seth Rogen, harnessing humor and hope to activate a new generation of advocates with solutions, empathy, and providing care to those who could most benefit from this support. Since then, HFC has raised more than $20 million and awarded over 405,000 hours of in-home family care. Lauren is on the board of California's Institute of Regenerative Medicine and sits on the California Alzheimer's Task Force as well. Please let us welcome Lauren Miller Rogen.
Hello. Hello. Do you want to? Okay. Sorry, we're having some technical difficulties over here, but that's okay. We're going to keep on going. I'm so happy to be here with all of you today. This is my 3rd year in a row, I believe, moderating this lovely conversation. I am always learning so much from this group. We've gathered an amazing panel of neurologists. We, of course, have your amazing questions that you submitted in the registration process. Thank you so much. That is what keeps this conversation so interesting, is your very smart questions that, of course, everyone wants to know all the answers to. A bit about me before we get started. As they said, I'm Lauren Miller Rogen. I'm the founder of Hilarity for Charity, HFC for short. We started HFC in 2012, shortly after my mom, Adele, had been diagnosed with Alzheimer's when she was just 54 years old. After seeing my family, my father, who was her primary caregiver, care for her for a number of years, we realized that we had an opportunity to bring young people into the conversation, to use our voices and to spread awareness of this disease. And what it is like to care for someone with it, and of course, how you can take care of your own brain. So in the 11 years that HFC has existed, we have supported caregivers with programming like support groups and seminars, and provided them tools to get through the journey as a caregiver. But we have also created brain health research programming to teach young people how to care for their brains. And we every day support caregivers through their journey with our respite program, providing actual at-home care to people who are caring for the loved ones at home, and are always doing what we can to teach people about their brains. So with that, let's start. I'm going to introduce our incredible panel of neurologists who are with us today. You're going to turn on your cameras one at a time, give us a little bit about yourselves, and then we will dive into the conversation. So we're going to start with Dr. Kremen. Welcome, Dr. Kremen.
Hello, how are you? My name is Dr. Kremen, and I'm a behavioral neurologist at Cedars-Sinai Medical Center, where I direct the clinical trials program and also am one of the clinicians in our memory clinic. And I'm also the director of the neurobehavior education program, where we're training new fellows to learn how to be behavioral neurologists. So thanks very much.
Welcome, Dr. Kremen. Dr. Perrin, you're up.
Hi, I'm Dr. Brand. Yeah. I'm at the memory clinic at UCLA, also part of the Kagan clinical trials. I'm an assistant professor here.
Great. Dr. Urban, you are up next.
Great. Thanks so much. Happy to be here. My name is Dr. Travis Urban. I'm a behavioral neurologist. I am the associate medical director at the Ray Dolby Brain Health Center, which is the big memory clinic part of Sutter Health in San Francisco.
Wonderful. And Dr. Skylar Scott.
Hi, everyone. I am thrilled to be here. My name is Irina Skylar Scott. I'm a clinical assistant professor in the Department of Neurology and Neurological Sciences at Stanford. I'm a principal investigator for 2 drug trials for Alzheimer's disease, and my other passion is lifestyle activities for staving off dementia and Alzheimer's disease in particular. And lovely to be here. Thanks all.
Amazing. And last but not least, Dr. Melina Henry.
Hi, everyone. Thank you, Lauren. I am Doris Molina Henry. I'm an assistant professor at USC's Department of Neurology. I am a neurobiologist by training and a co-lead for the Recruitment, Engagement, and Retention Unit, associate co-lead for Recruitment, Engagement, and Retention Unit of the Alzheimer's Clinical Trials Consortium. So most of my work is more in the engagement and retention and recruitment of individuals into clinical trials to prevent and treat Alzheimer's disease.
Amazing. Thank you so much for everyone for being here. And we're going to get into it right away because we have a long list of great questions with a lot of really good information to share. So let's dive in. We're going to start with an overview of promising drugs that are currently available or expected to be available very soon. Let's get right into it. Dr. Kremen, do you want to go first?
Sure. I think before we get to the main medications that I think we're going to spend some of the time talking about today, I just wanted to give an overview in general of what's going on in the landscape of Alzheimer's drug development. Right now, there's about 141 unique different drugs that are in the pipeline, which is incredible. And that there's about 35% of them that are actually in phase 1. What that means is that we have 3 phases. Phase 1 is like very small groups of people that we're looking at to see whether the drug is, safe. And then there's phase 2 where we have actually testing it in the people that we want to know if the disease, so people who might actually have Alzheimer's. And then phase 3, big trials, lots of people to really see if we can follow up on what we might have seen in phase 2. And what's really exciting is that there's a lot of new phase 1 things just getting off the ground that are in development, and it covers the gamut. So we're going to be talking today about some of the new treatments that target amyloid. That's really what we're going to be speaking a lot about today. But just to know that there's all these other drugs out there that are targeting tau, which is another one of the main proteins that we see in Alzheimer's disease that we think are causing some of the problems that we see. But not only that, beyond that, we have all these other different things. We have drugs that are looking at the connections between neurons, which are synapses, so changing synaptic plasticity. We have other drugs that are regenerative, looking at how we can regenerate neurons and maybe be able to improve the connections. We have other drugs that are looking at metabolism, for example, glucose metabolism, other things that are looking at inflammation. So what's really exciting, I think, about right now in the pipeline is that there is a huge number of drugs that are going to be coming. Hopefully, we'll see how far they make it through. We know that it takes, on average, about 15 years to get out of the mice realm into patients. But what's really exciting is that over the past couple of years, this has really expanded. So it's going to be really an exciting time, looking forward to seeing what's going to really work in humans. So I'll just give an overview of sort of the drugs I think that we're going to be speaking about, and then let everybody else sort of comment on what's been going on. So as many of you probably heard, one drug was approved, and there's another drug that we think is going to be approved. The first one that was approved got provisional approval in January of 2023, and then got full approval in July of 2023, which is lecanemab, or Leqembi. And this is a medication that is an immunomodulator. It essentially targets amyloid in the brain and pulls amyloid out. And what was exciting about this study is that not only did they see that it can definitely pull amyloid out of the brain, which we have seen in previous drugs, but this looks like it really can slow down cognitive and functional decline to some degree. And that's the first time really that an Alzheimer's drug has gotten full approval, not just because of the biology, but also because of the clinical efficacy. The other drug that you may be hearing about is donanemab, which doesn't have another name yet, at least not that I know of. And the rumor is that it may be approved before the end of the year. And there's only about like 6 weeks left in this year, so we'll see what happens. But that's another drug also targeting amyloid. They're both very similar in that, again, they are infusions that when we get them, they target amyloid and pull amyloid out of the brain, and both have shown a slowing down in cognitive and functional decline. So that's very exciting. It's very new, but and very exciting, but there's a lot of things that come with that. And I'll let my other colleagues sort of talk about some of the benefits, potential risks, and what they think about this drug.
Sorry, I can jump in briefly next on that. I mean, I think like this current phase that we're in is just incredibly exciting. I mean, we have this therapy that is the first one to show some kind of decline in the rate of decline. And that's really just our first foothold in the disease, right? We've had so many failures before, but we're starting to get traction, right? And I think that, there's many other things coming down the pipeline that Dr. Krimen talked about that are just going to keep building on that. So we're in this really exciting, very momentous era for Alzheimer's drug therapies. I think there's a more specific question about like the side effects that come later. So I don't know how much I want to say now. It's not a drug that's for everyone, I guess is the fundamental point there. It's for people who are in the early stage of the disease. So people who have either a diagnosis of MCI or mild dementia. Right, there are side effects that are potentially serious. And those include things like brain swelling, brain bleeding, obviously concerning. And I don't want to steal other people's thunder, but we'll certainly delve a lot into that. But again, this drug, very exciting, but it's for the right patient right now.
I'll just hop on and echo some of what Travis was saying. So at Stanford, some providers are offering lecanemab and others are not offering it. And you might wonder to yourself, why wouldn't somebody offer a drug that's been FDA approved? But there's a little bit of controversy in the field that's worth knowing about, because, yes, there was what's called a statistically significant difference between the drug group and the placebo group. But what we're debating amongst ourselves is it clinically meaningful? Is it something where patients and caregivers would actually notice a difference if they're on this drug? And so the key point that we'll start talking about here is that there's basically a 0.5 point difference on an 18-point scale between drug and placebo. So this is a scale where patients and study partners are asked, about memory, about judgment, about their hobbies, about their function. And so, we have to ask ourselves, does 0.5 point on an 18-point scale matter? And some people will say, no, it should really be a difference of 2 or 3 points. And then there are also the potential side effects to consider, which we'll talk about. I will say, as personally, I am offering it to my patients, but I'm being very ginger about it because of the high risk of side effects and because it only works for select patients. I think we're bringing it out, but bringing it out slowly and kind of monitoring patients because we want to make sure it's effective for our patients and we want to make sure we keep our patients safe.
I think it's worth getting a workup and then making an educated decision. So if there's a concern for Alzheimer's disease, you're noticing a decline, and getting an MRI to evaluate to see if there's any strokes or any microhemorrhages that could preclude you from getting the genetic testing that's needed to get done, which could determine your risk of bleeding or swelling and the side effects, and then also checking to see if you have either CSF analysis of amyloid in the CSF or in the spinal fluid, or getting an amyloid PET scan to see if you have the markers, and then trying to gather all that information and see if that would be the right decision for the patient.
I won't speak as a neurologist because I am not one. As I mentioned, I'm a neurobiologist, but I will speak from the side of what this looks like in the field. And I do want to piggyback on some of the comments that my colleagues have made and how exciting this time is. And I think it really has shown some light at the end of a very dark, long tunnel for many, many years. And there's some excitement. There's a lot of excitement around that because we see paths for future treatment. So while it may still be, the scale of the impact of a treatment like this one might still be limited to a select few people, the pathway for us to identify other treatments that can build on this new knowledge is now there. And I think that you see that in the number of studies that are ongoing to test different treatments, different molecules, and to see their impact. The fact that we are considering the heterogeneity or the variety of presentations, pathologies that present in the brain of different people that manifest as symptoms of dementia. And so these different individuals are aiming to address these challenges across these studies. I think the other exciting thing is that we're looking at a future where we can prevent the disease. And so not only are we looking at delaying the progression of the disease, but now we're expanding to finding ways of preventing those symptoms from ever manifesting, with the hopes that one day we can prevent the devastating impact of the disease in individuals before it even begins. And so those studies are ongoing right now, particularly with this drug that has now been approved in individuals at early stages. And we cannot wait to see the outcome, and our hopes are high that we might begin to elucidate the pathway for prevention and get earlier and earlier at tackling this problem.
So I think, one of the things that maybe people are wondering about is, how do we figure out who's qualified for this medication and what are the steps? Because it is quite complicated. And I think that we've heard in the news and the media has talked up these drugs, and then you call up a hospital and they say they're not offering it, they don't have it yet. And there's this question of what's the delay? So I think we can sort of explain the facts on the backside. What is the delay? What have the delays been, aside for the fact that we were waiting for, full FDA approval and everybody was sort of waiting for that? But this medication requires a bunch of different steps. And Dr. Perrand, was talking about some of them, which is that this medication, because of the potential side effects, but also because it requires actually knowing for sure that you have the biology behind Alzheimer's disease, takes a little bit more work than the medications that we've had available up to this point, where we sort of, we got the story, we could tell that somebody was having a memory problem, maybe we got a brain MRI, we got some cognitive testing, and then we could just decide to give a drug. This requires more. So not only do we need to get a story that sounds correct for somebody having short-term memory problems, that it's progressive, that sounds like something like Alzheimer's, we have to get the brain MRI, because not only do we need to rule out you've had strokes, but we need to make sure that you really don't have any bleeding in your head that you might not know about. Sometimes people have what's called microbleeds. And this medication, we don't feel comfortable giving it if you have microbleeds in your head. So that's the first thing. The second thing is you really have to qualify by either having mild cognitive impairment, which means that you have a decline in cognition, but not in function, or you have to have mild dementia, meaning, you have a decline in cognition and function, but it's only mild. And somebody needs to determine that, whether that's your physician or a neuropsychologist, but that really has to be determined because this medication isn't for people who have moderate or severe dementia. So that's the second step. The third is once you pass that, we need to have proof that you have amyloid. We didn't used to have to do that, but for these drugs, you do. Why would we give you a drug that pulls amyloid out of your brain if you don't have amyloid in the first place? So that step is that either you need to get an amyloid PET scan, which previously has not been able to be very accessible because it's been expensive and not covered by insurance. That's now changing to some degree. We think Medicare is going to be covering that. Or there needs to be a lumbar puncture, a spinal tap to look for amyloid in the CSF, or maybe a blood test will be available. That's starting to become available, but somehow we need to have proof of amyloid. So that's the third thing you need. So if you make it through the fast 2, but you don't have amyloid, you're not going to make it to this drug. The fourth thing is that because we know that certain people with a certain gene type, an ApoE4 gene type, have increased risk of bleeding and swelling, many of us are asking our patients to also get this tested as well, because we just need to know what to expect. Not to say that people without the, with E4 might not, they can also have brain bleeding and brain swelling as well, but that's helping us. And for some institutions, they may decide if you have 2 copies of E4, you get 1 copy of a gene from your mom and 1 from your dad. If you're a double E4, which really increases the risk of bleeding, maybe we don't feel so comfortable as a physician. We may decide that, you don't want to, but that's a physician comfortability thing. It's not totally excluded from you being able to have it. So you have to go through all those things before we can decide. And many hospitals are trying to figure out, maybe we need a panel of physicians to make sure that we can review, to make sure that somebody really meets the criteria, not because they want to gatekeep, but they want to make sure that everybody's safe and that they are appropriate. And then there's a lot of coordination because this is an every 2-week infusion. So that means in getting, the infusion centers involved. Then we also have to talk to the neuroradiologists so that they know, hey, if somebody has a side effect, they need to know that they're on this drug. They need to know how to read that appropriately. And we have to educate the ER doctors as well. So there's been a lot of work on the backside, which explains partly the delay that you're seeing on the front side. Like, why can't I just get this drug? It's much more complicated than some of the others. And I'm sorry to hog it. I just wanted to make sure that everybody kind of knows the steps.
Not hogging it at all. You guys just dropped some serious knowledge there, and there was a lot of big words and a lot of science, but I think all of that was extremely helpful and really sort of laid out the landscape. So thank you. We had a question actually about some of the, the older drugs and Namenda, the Ariceps. Are those still around? How do these relate to those drugs? Where are we with sort of, what's been around in the past?
Yeah. So donepezil, Namenda, still certainly available, still used in my clinical practice. And that these therapies are different than lecanemab in that they're just treating the symptoms of the disease. They're trying to boost cognitive function a little bit. And they haven't been shown to really slow down the decline like lecanemab has been. So we're using them in tandem with lecanemab. They're not just totally gone out the window. I think there was another aspect too of this of, so many other things have failed on the amyloid side. Why all of a sudden has this one come along and shown benefit? And what we've seen in the trials, it's really that for the first time, we're showing that we can take the amyloid out of the brain. That's been key. And that we've only been able to show that in the last few years. And it's a question of how fast we're able to get it out of the brain. The people that we can take to total amyloid negativity, where we don't see any sign of it in their brain anymore, the trials where we're seeing more of those participants who are getting to that amyloid negative threshold are the ones where we see the drugs working. Aducanumab was the prior drug before lecanemab, lots of controversy around it. Long story short, one trial worked, one trial didn't. And the sort of sense there is that it wasn't clearing the amyloid fast enough. It had a slow titration to get up to the full treating dose. So lecanemab, we just started everyone out right at the full max dose, more people were getting clearance, we're seeing more clinical effect. Yeah.
Before I move on, does anyone want to add to that? Okay, great. Just want to make sure no one has any good stuff they're hiding.
I
So
just thought I'd add some kind of logistical pieces to this as people listening in think about whether this is right for themselves or their family members. Just some logistical pieces. So one, it is an intravenous infusion if you get lecanemab, and donanemab, if it's approved, will be the same way. So for lecanemab, you have to come in every 2 weeks to get the infusion. The infusion lasts an hour, and that doesn't include the time beforehand, the time where they monitor you afterwards for infusion reactions, which are a significant risk. A quarter of patients who are on lecanemab had a potential infusion reaction. The other thing to keep in mind, and I think we'll talk about it more, is the cost. So Medicare has said that it'll cover 80% of the drug, but that still means that you have to pay $5,300 a year out of pocket for this drug and have to have the means to do that. And that doesn't include the potential costs of ancillary testing, like the genetic testing we've been talking about, that may not be covered by insurance. So those are really key kind of day-to-day life considerations regarding these drugs.
And how does Medicare play into using these drugs and getting access to them?
So Medicare, so the drug itself is over $20,000, but Medicare has said they'll cover 80%. So if you're on this drug and you have Medicare, you still have to pay over $5,000 out of pocket every year on an annual basis. And then you may have to pay for the genetic testing as well, which can cost a couple $100s. And then if you get the amyloid PET scan, Medicare has recently said that they are going to allow coverage for it, but it's going to be decided on a regional basis. And so we as a field are still trying to figure out how that works, and will everybody be covered, or will there be people who get denied? Because if they do, then that's many thousands of dollars. So the risk here, on a kind of serious note, is that we have to worry about whether we're going to create a two-tiered system where people who can afford it get treatment for Alzheimer's disease, and people who can't are left behind. And that's something that we all have to be thinking about as a field, because we don't want that to happen.
I spoke to
Certainly
the
an
company,
important conversation to have.
I spoke to the company actually recently. They've been calling me, and they said that they offer special funding for people with that are low income. They'll even provide the coverage for, depending on your income scale, but provide the coverage for it. Also, they would offer assistance for people who have Medicare and still need financial assistance, where they would help to cover it. And then for people who have commercial insurance, where there's additional co-pays or extra deductibles, they have a special system where they would give you a special card where they would pay, depending, income is irrelevant, and they can pay $10,000 up to that with a special card. So it's worth reaching out to the company and finding out more about what type of financial assistance can be utilized by the company and what your insurance covers. So it's reaching out both to your insurance company and the company, and they have a really nice support group, support number and support system, and they're really active in trying to get people coverage. So you just look at their website, leqembi.com. And they have the number there. And if you need any additional information, reach out to me as well.
I think the one other cost is the MRIs. So this drug, and many like it, this is not the only one. This is a class effect. But because we're concerned about brain bleeding and brain swelling, the recommendation is that you have to have a brain MRI within a year before starting the medication, just to make sure that there's nothing unusual that would stop you from, moving forward. But then within the package labeling, you are required to get 3 more MRIs along the course of and it's mostly clustered at the beginning, because that's when we expect the greatest likelihood of brain bleeding and brain swelling happening, although it could happen at any time. So there are MRIs that are required, 3 more of them, like after the 5th, the 7th, and the 14th dose. So you're looking at the cost of 4 MRIs. And then if something, God forbid, were to happen, there could be other ones that, they need to check up with you every month. So again, we don't really know how much that's going to be covered and whether it will be covered at all. Usually you only get coverage for about 1 MRI per year. And so it's a little bit unclear there as well about what that's going to entail. So just to put that out there as well in terms of considering it, and to the point of, not wanting to become a 2-tier system, I can say that I think a lot of hospital systems are really concerned about equitable ability to like really provide this. Nobody wants to not be able to provide this to everybody. And so that's another reason why it's a little bit of a slower rollout. Amongst all the other reasons is I think there are a lot of hospital systems that are looking and saying, how can we make sure that no matter who comes to our door, that we're going to be able to give this person this medication if they qualify just because of their healthcare situation, nothing else. And if they can't afford it, how are we as a hospital system going to be able to try to help, every patient that comes? So it's definitely a drug that's exciting, but not without its challenges.
Let's move on to some other non-medical related questions. Really very important question I think a lot of people unfortunately probably can relate to is, what if we can't find an available neurologist within 300 miles? How do I find a good dementia doctor? That is such an important question. Dr. Molina Henry, do you want to start with that one?
I can kick us off, and I hope that others have insights on this. And I think that's a big challenge. And I know that there are a number of reasons for that. But it's always the best way to start is connecting with your PCP, your primary care provider. I still think that that's the initial way to find what avenues and possibilities there are for follow-up and referral to a neurologist. But I welcome what others have to say in that regard as well.
I mean, I think there are a couple things with that. I mean, for one, we as neurologists see memory impairment, but I mean, also geriatricians are seeing a lot of memory impairment, are potentially more numerous in some instances than us, and maybe another avenue. And I'll also say that telemedicine, although it's not ideal, but we can do a lot of the things for dementia evaluation over a telemedicine eval. I still would like to see someone maybe once at least getting the initial diagnostic workup, but we can still reach people that way and get a lot of good data, even just over the video, even if it's so far away. I mean, that distance, it gets harder with like access to therapies and MRIs and things like that, which, we're all trying to think through how we make that accessible. But, there are certainly ways. If you live that far away, it doesn't mean you can't see someone in an academic medical center or other subspecialty center.
One other thing to add is this doesn't supplant a physician, but it's worth knowing that the Alzheimer's Association has a 24/7 helpline, and no question is too big or small. So if you don't have a doctor you can call right away, if you go to their website, which is alz.org, the number is listed at the very top of the page. And you can give them a call anytime, even if it's 2 in the morning and you have questions. So that's kind of a nice additional resource that's available to anybody.
Amazing. This is a question that I feel that I'm going to answer myself, which is, how does one qualify for respite care? We at HFC offer respite care through a partnership. We provide in-home care. And you go to our website and you fill out an application and you tell your story. And we have a group of people who evaluate those. And being a caregiver is a very full-time, heavy load, and so it is about accepting that is a load that often can't be carried alone and asking for help. And so putting your story out there and exploring whether it's through HFC or in your local area. Of course, talking to your primary care physician can often be the beginning of a journey to get help and to get care. So so that is a good place to start with that. Let's go into non-Alzheimer's dementia. Unfortunately, there are many types of dementia. Dr. Kremen, do you want to walk us through maybe sort of a brief overview? This is, I mean, we could have our own hour-long conversation. This is a big question, but are there any exciting advancements, I guess we'll say, in other areas of dementia?
Yes. So, yeah, I think that it's important for us to focus a little bit, on things that are not Alzheimer's. It's not Alzheimer's all the time, just a lot of the time. But some of the other dementias, for example, dementia with Lewy bodies, that's the second most common neurodegenerative dementia. There is a lot going on. So for those of you who may not be as familiar with dementia with Lewy bodies or DLB, sometimes it gets confused for Alzheimer's, but these patients, generally speaking, might have spontaneous Parkinsonism, might have formed visual hallucinations. They have a lot of fluctuations in their cognition, where one day they're very sharp and another day it might be really kind of spacey. And they have a lot of visual spatial problems, might act out their dreams at night. And it's caused by a different protein. So with Alzheimer's disease, we have the accumulation of amyloid and tau, and in patients with dementia with Lewy bodies, they actually have the accumulation of alpha-synuclein, which is actually the same protein that builds up in Parkinson's disease. It's just that it's building up in a different place than as the first place that it goes to. And some physicians even consider Parkinson's disease and Lewy body kind of all the same thing. It's just a spectrum. But in any case, Lewy body, what's really excited, there's some drugs that are now looking at actually blocking alpha-synuclein or reducing it. So Georgetown University has been one of the leaders in repurposing medications. So nilotinib, I don't think I'm saying that right, but there's a bunch of drugs that are basically used against cancer. So they're already being used. And so we already know sort of what their safety profile is. And now they're usually used for people who have chronic myelogenous leukemia. But they're finding that they actually reduce oxidative stress and they reduce alpha-synuclein, which is pretty neat. So these are like in phase 2 studies where they're looking at people who have dementia with Lewy bodies, but we're going to see how this works. But so there's 2 medications like that they're looking at. There's also some other ones, niflamapimod. I know I'm not saying this right, niflamapimod. I even heard it at the recent trial meeting and I was like, oh, I think I'm still saying it wrong. Anyway, but that is another one that's looking promising. I don't want to get into the mechanism because I think it's going to be in the weeds, but the exciting thing is that they're seeing some progress there, which would be really great because dementia with Lewy bodies has sort of, is behind. All these other diseases are behind where Alzheimer's is. In terms of frontotemporal dementia, which affects people when they're usually on average much earlier, usually under the age of 65, and they usually present at least behavioral variant with a lot of behavioral changes where people become really disinhibited, apathetic, their memory might be fine. These patients, they're actually looking a lot at targeting things at genes. So we again know that there's genes that are regulating, again, a protein called tau. It's a different form of tau than what you see in Alzheimer's. And then there's another protein that builds up that's called ubiquitin. All these things are protein-based. But what's really exciting is that we're seeing that some of these drugs are trying to change either the genetics surrounding tau or ubiquitin, and trying to either change how things are, like how the genes and the tau gets phosphorylated, or trying to modulate them, basically trying to modulate so that things won't aggregate, they won't build up, or to promote clearance. And again, like I'm just looking at a chart now, and there's probably about 7 of these tau drugs, and then maybe another 8 or 9 that are focused on ubiquitin. So just to sort of say, there are other drugs that are coming through the pipeline for these other types of neurodegenerative diseases. And so it's pretty exciting. Again, nothing yet quite ready for phase 3, like the big breakthrough that we've had recently in Alzheimer's, but there are other drugs in the pipeline.
I just have to say, I've been having these conversations for a handful of years now, and there's more confusing drug data than ever, but that means there's more hope than ever. And I think that is an amazing thing and worth noting. So that's a change that I've seen. So I think that's really incredible. I want to get into clinical trials, which are so important. How does one get into one? What can they expect when participating? Obviously, this is really important, but how can we make it more inclusive? How can someone join a trial?
So I'm happy to jump in on that, and just I look forward to what others have to say. But I think you can probably agree that none of the advances that we're discussing today would be possible without the participation of individuals across the full spectrum of the disease. And that is really what allows us to move forward. It's what allows us to accelerate and really make the important discoveries that will ultimately help us make progress and really reducing or delaying the progression of the disease, and hopefully one day preventing it. And so I think that really puts us at understanding how important it is to be involved, to be connected, and to participate in studies, particularly clinical trials. I think people often hear about Alzheimer's disease research, and there's a lot of studies, and I think it's important to participate across the board. But when you participate in a trial, you really are helping advance what is therapeutic and treatment science. We are moving towards now something that will have impact on a disease. And I think that's what's really critical of understanding the value of participating. When individuals engage across these backgrounds, across social demographic backgrounds, across race and ethnicity, then we're really expanding our understanding across different sub-pockets of the population that we're hoping to treat. And so that alludes to the importance of having people from everywhere and anywhere, and that have all kinds of different experiences in life participate in these studies. Our hope on the trial side, on the science side, is to make sure that those trials are inclusive. And we do so by constantly monitoring our eligibility criteria, who gets in and who is eligible to participate. But that is done critically, it's done very carefully, and it's done for the very reasons that have been mentioned before, to make sure that individuals are safe, that we are engaging individuals that are likely to benefit from the treatment. And so as individuals look for avenues to participate and contribute to what is very, very important in the landscape of Alzheimer's disease therapeutic, those are some of the things to keep in mind that really add that the recognizing the value that you add and how critical the participant is to the study, that we are putting concerted efforts to ensure that our trials are as inclusive as possible, but that there are trials and that there are different designs for different types of diseases within the dementia framework, if you would. And also, how do you get into a trial? How do you participate? And there's numerous gateways to do this. And we can be all very specific about the ones that are available at our institutions that I've heard recommended that people go to a place like clinicaltrials.gov. I think nothing's warmer and closer than talking to a provider, the individual that you see on a regular basis when you have concerns. And I noticed this is a question that has come up. You know, if you're not eligible for a treatment, if you don't have a diagnosis of a disease, what can you do? Well, this is an opportunity to get involved in a trial or participate in a registry. These are opportunities to be monitored, to sometimes have results, and know how you're faring cognitively. I think asking someone, sometimes it's word of mouth, sometimes we see studies in the media, other times we go to reputable institutions, go to the NIA and also, or the National Institutes of Health or Aging, and just investigating what's available and what might be the right fit for you. And I'm sure that others might have other avenues, but I think getting involved is yet as important as other things that you can put in place to prevent and mitigate your risk.
I'll just also like hop on that. I think it's for like boots on the ground, kind of how do I find a trial? With all things Alzheimer's, you can always go to the Alzheimer's Association website. They have tons of resources for everything, and the 24/7 helpline that Dr. Skylar Scott mentioned. They also have Trial Match, where they try to help you identify trials in your area. So you can also look at Alzheimer's Association. Clinicaltrials.gov is a little cold, to say the least, but it is there and searchable.
Yeah, I
For
wanted to
people, oh, sorry. Just that for people that who are cognitively normal, having complaints or have a family history, possibilities, observational studies, so sometimes that can be an option. And then there's some studies with medications as well, where they're trying to evaluate further the donanemab and lecanemab on the need to see if you have any signs of amyloid in the brain first, but those are trials that are being done for people that are cognitively normal. I'll let you answer, sorry.
Amazing.
Thank you. Yeah, so I want to echo clinicaltrials.gov is a good resource because you can search by location to find trials in your area. If you happen to live in the Bay Area, we do have clinical trials here at Stanford. The contact is memoryresearch@stanford.edu. Or if you forget that, just Google Stanford Memory Clinical Trials and you'll find the website right away. But we have we have trials for Alzheimer's disease, including a trial that prevents that tau protein, one of the 2 proteins that accumulates in Alzheimer's disease, from forming. We have a Lewy body trial. We have a prevention trial for people who want to stave off dementia and are cognitively normal. We have observational research. So we have a lot going on. And I imagine everyone here similarly has many people here have an active trials program. So even if you know, for example, oh, I see physicians at UCLA, if you Google their clinical trials program, there's often a website and a contact so that you can reach out and find out what they have on offer.
And I offer, along with what Irina suggested, we also have a registry or longitudinal study. This is the Alzheimer's prevention trials. It's known as the Alzheimer's prevention trials. It's an observational study, but it's also a gateway to participating in a trial should you be eligible for an ongoing trial. And this spans the entire country wherever there's a site available. So this is very similar to Trials Match, as was mentioned before. And I think it would be useful if maybe we added these in the chat, because I often hear people are trying to find a way. And particularly with APT or Alzheimer's prevention trials, this is for individuals who are younger and individuals who don't have signs or don't have symptoms of dementia. And so this is an opportunity for those that want to just get connected and see how their cognition is faring, but also know firsthand if they might be eligible to participate in the trial based on how they're progressing. It's an opportunity for them to be engaged that way.
Amazing. Thank you. We'll keep going. I'm going to be conscious of the time, but let's move into an area where I find lots of hope, which is in prevention and brain health. What's next in prevention? What can we all be doing to keep our brains healthy? What should, anyone, there's so many things that we know these days. Dr. Skylar Scott or anyone jump in on this very exciting area.
Yes, so this is one of my passions. And so if you take nothing else from this, maybe this is worth, it's worth thinking about what you could change in your life or what you could improve upon. And I think about this for myself as well. Think of me as giving you a prescription for a lifestyle activity that could improve your brain health. So I like to talk about 4 things. The first is physical activities. There's really good evidence to support that physical activity can help with you with your cognition. So we recommend a minimum of 30 minutes a day, 5 times a week of moderate intensity aerobic exercise. So moderate intensity means you could talk to someone if you tried, but it would be a little bit difficult for you. So you can do whatever you like, anything you enjoy. You can dance in your kitchen, you can go out running, you can go for a swim, whatever it is that you like to do. The second thing is diet. So the diet that's shown to be best for brain health is called the Mediterranean diet. So that's lots of fruits and vegetables, especially leafy greens, using olive oils instead of other oils. If you're going to eat meats, eat lean meats like chicken and fish, lots of lentils, lots of nuts, trying to avoid processed foods to the extent that you can. And there are other diets that are helpful too, but that's just one that I wanted to highlight. And then the other 2 pieces are intellectual engagement and social engagement. So as far as intellectual engagement, that old adage of use it or lose it is absolutely true. So do, again, what you enjoy. So some people like crossword puzzles. Some people like learning a new knitting pattern. Some people like learning a new song on a musical instrument. Whatever it is for you, just do something that challenges you. And then the final piece is spending time with friends and family, because it turns out that's really good for the brain as well. And if you can do all of the above, even better.
And what about sleep?
Sleep is fantastic. We recommend, generally about 7 to 8 hours of sleep per night if you can get it. And we don't live in a perfect world, but in an ideal world, you would be able to kind of fall asleep pretty quickly and stay asleep throughout the night without multiple wake ups throughout the night. So I'm happy to talk more about that, but that's really the goal.
I'll just share that I have been on a sleep journey myself for the number of years and started tracking. There's a number of wearables that you can do that you can, track your sleep, and found that I was getting very bad deep sleep, which is really important for your brain. I've heard a lot of smart people say that when you sleep well is when your brain takes out the trash. And so you can improve your sleep. You can get cooling pads and weighted blankets and masks and a sleep routine and it is doable. And I can feel a difference in my life. And so that's a huge one, I think. Anyone else want to jump in on brain health and all the exciting things we can be doing?
So I'll just add that there's been a lot of recent studies looking at vision and hearing. And those are other things that are very easily evaluated and hopefully treated, though I know sometimes hearing can be a little bit difficult. But in general, it's really important. If you can't hear very well, or if you can't see, then you're missing a lot of information. And I've had some patients tell me, well, I don't go out very much and I'm not, conversing with people. It doesn't matter if I don't wear my hearing aids all the time, but it does, because your brain abhors a vacuum. And even if you're not talking to somebody, your brain still wants to hear the birds and wants to hear the ambient sounds around you, because it helps you with orientation and keeps you, really grounded in life. So it's really important to make sure that you get your vision checked, get your hearing checked, because there are things we can do for that. So
can I add, in terms of things we can do, and I know this overlaps quite a bit with what was mentioned, but is the idea of if you have a comorbidity or a chronic condition that can be managed, ensuring that you're managing it. When we're talking about high blood pressure, hypertension, when you have diabetes, these are things that are known to reduce your risk of developing dementia, because they're huge contributors to your risk of dementia. So making sure you're taking your medications, making sure that you're incurring in those lifestyle changes that can help you manage those particular conditions is always going to be very beneficial.
Thank you. Thank you, everyone. And I'll just add to that, and that's breathe. I have just, there's so much going on and we have so many distractions in our life. The traffic here in LA today was horrific because of the rain, everything stops. And same with the traffic in Northern California with the conference in San Francisco. But just breathe, just try to breathe and do that heavy breathing is really good, I think, to just reset. It is that time. I knew things would just fly by, but I cannot thank all of you enough. I cannot thank our audience for attending today, and such valuable information. And there was so many things in the Q&A that said, could you repeat that? Could you, share that with us? We will send you links to all these wonderful organizations, including HFC. Please support them. They're a dear partner to Kensington. And a copy of the webinar to share with friends and family. And we encourage that. So again, thank you. And it's mid-November. Happy Thanksgiving to everybody, and be safe and have a good evening or a good afternoon. Thank you so much.